Welcome and thank you for joining us today for the SPH Analytics webinar, Improving Your Star Power. We will have a question and answer session following our presentation today. Please type any questions you have for our presenters into the Q&A tab of the WebEx portal at any point during the presentation. We will also be recording today's webinar and will make the recording as well as the slide deck available to our attendees following the webinar. Now I'd like to introduce our first speaker, Dr. Roki Chauhan. Dr. Chauhan has been the Associate Chief Medical Officer for SPH Analytics since early 2016. He was a family physician in clinical practice for 16 years and then a health plan executive with Premera Blue Cross in Washington and Alaska for 16 years. Dr. Chauhan has been doing independent consulting to health plan providers and other healthcare organizations since 2015. Dr. Chauhan will lead us off in the agenda where we will be discussing an overview of Medicare star ratings components, and then we will have other speakers who will go into STARS improvement with SPH Analytics, regulatory requirements for star ratings, how to improve experience with CAHPS and the member experience, and how to improve quality through HEDIS quality improvement strategies, following with our Q&A session. Thank you for joining us today, Dr. Chauhan.
Thank you and good morning, everyone. Next slide, please. I'm going to take a few minutes to set the stage for this webinar, and so to do that, I'm going to dive right in. Go ahead to the next slide, please. As you know, Medicare star ratings are determined on the basis of several categories as shown here: quality of care, member satisfaction, as well as administrative performance and compliance of the health plan. The pie diagram shows the point distribution of various measures. And of course, you know that HEDIS and CAHPS make up almost 50% of the points. Let's move on to the next slide, please. Another way to look at the ratings are in these groupings as shown here. And one of the things that I've done is I've looked at multiple health plans across the country, and what I see is that plans address these in very different ways. There is no cookbook, there is no roadmap. What I've seen in plans that improve their scores year over year is a deliberate focus with multi-year plans. Rather than waiting for the results each year for HEDIS and CAHPS scores, they develop multi-year plans based on their trends to address the areas that will give them the biggest bang for the buck. More importantly, they use data to develop strategy. They anticipate what to do based on claims data, membership data, and survey data to see where to focus their attention. For example, one plan addressed breast cancer screening by looking at zip code data, and they found pockets where the rates were extremely low, and they put mobile mammogram units in Walmart parking lots based on zip code to make it more convenient for their members. So they didn't target the entire state. They targeted those areas that mattered. And what they saw was significant improvement in their rates year over year. Another thing that plans do who are successful is they listen to what providers are telling them about their challenges in improving care. No surprise that they're your direct link to your members, their patients. Successful plans have provider advisory groups focused on quality. And while we're speaking about providers, I would be remiss in saying, if I didn't say, that they are essential to improving the star ratings. Some plans have instituted financial incentives for providers in addition to providing care gap reports. Or if financial incentives are not possible due to budget constraints, some plans provide comprehensive care gap reports to providers that cover both their Medicare population and their commercial population and demonstrate how improving HEDIS and CAHPS will also benefit them in the macro program, be it MIPS or APMs. And as you also know, by 2019, providers will need to include their commercial members to qualify for MIPS or APMs. Next slide, please. One of the things I wanted to share with you is the weighting of the various measures. Go on to the, there you go, thank you. The ones highlighted in yellow have a weight of either 3 or 5. If one has limited resources, then some plans target the areas with higher weighting. But they also don't ignore the others because, as you probably know, every fraction of a decimal point matters. They focus on the rates with higher weights, but they also are disciplined in their approach. Next slide, please. I know that the focus of today's talk is how to improve star ratings, but I wanted to also include Medicare Advantage risk adjustment. And the reason I say that is that I've seen health plans work on ways to improve their HEDIS and CAHPS scores, and then they also focus on their risk adjustment scores in silos. So, for example, many times it's the quality department that's focused on HEDIS and CAHPS, and the finance or actuarial department that focuses on risk adjustment. These activities should be coordinated with clinical folks who understand how provider practices work. I've also heard providers complain that sometimes they are contacted by as many as 6 or 7 different departments from a single health plan, rather than being contacted once on a regular basis with a comprehensive report that shows them which areas to focus on. Successful plans do this in an integrated, concerted way. Something that's not covered in the slide presentation is that I firmly believe that a focus on population health is becoming more and more important. And there is a convergence between health plans and providers to address population health. Witness the new NCQA population health standards that will go into effect next July, which as a family physician makes sense to me, treating the whole person rather than managing single chronic conditions. I would not be surprised if CMS does not start attaching higher weights to population health management as well. So I ask you to keep all of this in mind as you listen to my colleagues today, and hopefully you can see how SPH offers solutions to help with all the areas that I have discussed and more. I will stop here so that you can now hear from Suzanne. Thank you.
Thank you, Dr. Chauhan. Our next speaker is Suzanne Cogan, Chief Commercial Officer at SPH Analytics. Suzanne has spent 20 years in healthcare IT in a variety of care settings, inpatient, outpatient, and cross-continuum. Most recently, she was with Orion Health, working on interoperability and population health across states and between payers and providers. Welcome, Suzanne.
Thank you, Terry. So I just wanted to set the stage a little and give you a quick overview of who SPH Analytics is. We're fortunate enough to have many of our clients on this call, but for those of you who don't know us, we have a large presence in both the provider and the health plan markets in this country. We manage over 10 million patients a day through our various databases. We do about 8 million outreach phone calls to patients and members per year, 6 million surveys that we mail out per year, and 2 million email surveys per year. We work with over 250 health plans. We have deep integration with over 40 different EMR systems, which we'll talk about in a bit when we're talking about pulling in clinical data to help improve with HEDIS scores. And we have 10 CMS and NCQA accreditations. So a little bit about the context, the business setting as to why we offer the services that we do. So as everyone on this call likely knows and experiences on a daily basis, healthcare organizations are essentially fighting a battle on 3 fronts. There are clinical challenges with the rate of chronic conditions across most organizations' populations. There are financial challenges with the shift from fee-for-service to fee-for-value, and healthcare organizations sitting in this hybrid world at the moment. And then there are, of course, experience challenges, what with the increasing consumerism in healthcare, the services that many members are expecting, and the fact that many of your organizations are measured and reimbursed based on your members' experiences. So we develop our solutions with those 3 categories in mind, clinical, financial, and experience. And if you think about them coming together, this is essentially the triple aim. So on the clinical front, improving the outcomes of populations. On the experience front, improving patient experience, and on the financial front, reducing the cost of care. And we do this in a way that where we think that the intersection of all of these areas, there's a lot of value that can be created, and we call it the nexus. And all of our solutions have a singular underlying data platform that we call our nexus platform underneath. And we don't just apply software and analytics to these problems. We also take a very holistic people and process as well as technology approach to solving any challenges that our customers may face. So how it looks laid out, as I mentioned, all of our solutions have a singular data warehouse underlying them that we call the Nexus platform. This is where all of the data comes in, whether it be the voice of the consumer via our survey work, or pulling in clinical data from EMR systems to expose care gaps. And then each of our applications sits on top of that. So on the far left, you see our clinical improving outcomes applications that we brand Population Care. In the middle, you see our financial applications that we brand Population Value. And on the far right, all of our survey solutions, whether they be mail, email, or phone outreach to patients and members, that we brand under Population Engage. And so lastly, before I turn it over to some specifics about the CAHPS and improving member experience scores, as we know, and as we know from Roki's section, the star rating is driven by CAHPS scores as well as by HEDIS scores. And one of the kind of a common set of challenges that we hear from our health plan clients across the country is, in order to get to that stars improvement, not only, of course, do you need to measure and improve your member experience on the bottom right, but there are three other big buckets that are challenges for many of our customers. On the top left is accessing clinical data from the multiple EMR systems that are in use across their provider partner organizations. This is a fragmented world. It's costly and difficult for providers to extract data from the EMRs and extract just the data for a particular health plan's members and send it to the health plan in the format that the health plan needs. On the top right, and it kind of goes hand in hand with the access to the clinical data, but then how does the health plan really enable their providers that they're in value-based contract arrangements with to identify and then, more importantly, to close the care gaps in a timely manner so that they're not scrambling at the end of the year to bring patients into the office. And then on the bottom left, and this applies in particular for our health plan clients that are on the exchange and experiencing influxes of new members during open enrollment that may be sicker than the average, quickly getting a grasp on those new members' history and risk in order to be able to take appropriate interventions for the higher risk members. So those are four areas that we see challenges among our clients and that really go into impact the HEDIS and their CAHPS scores and ultimately their star rating. And so I'm going to pass it over now to Steve Brightwell and then Linda Lynch, who are going to focus very specifically on ways to improve the experience or the CAHPS side of the equation.
Thank you, Suzanne. As a reminder, we will have a question and answer session following our presentation today. You can type questions that you have for our presenters into the Q&A tab of the WebEx portal at any point during the presentation. Now I'd like to introduce our next speaker, Steve Brightwell, Vice President of Health Plan Sales for SPH Analytics. Steve's healthcare experience spans more than 25 years, including tenure with leading healthcare organizations such as William Mercer Consulting, Kaiser Permanente, and Alere Health. Welcome, Steve.
Thank you, Terry, and thank you, Suzanne. I'm going to discuss today regulatory requirements for star ratings. So we've seen the data collected for Medicare star ratings comes from a variety of sources. In this section, we're going to briefly cover the two regulatory surveys, the CAHPS survey and the HAAS survey. First, let's go over the Medicare CAHPS survey. It's designed to assess experiences and satisfaction with the health plan from a member's perspective. The survey is administered beginning in March and runs through June. And the survey is mailed and then followed up with phone calls from our call center agents in the Atlanta location. The flu vaccine question, a handful of composites, and rating questions all support star ratings measures. SPH Analytics is a CMS-approved Medicare CAHPS vendor, and we've been conducting the survey since the program first began, and we've worked with many of the top plans throughout the nation. In addition to the survey administration, these plans receive our online reporting and insightful analysis of their Medicare CAHPS survey results in an easy-to-understand format. Our goal is to empower plans with the information they need to make highly targeted improvements in order to increase their star ratings. First, let's go over the Medicare CAHPS surveys. I'm sorry. Next slide. The Medicare HEDIS survey is designed to assess a plan's ability to maintain or improve the physical and mental health of its members over time. The survey is administered annually to a new random population, and follow-up surveys go out every 2 years to previously surveyed members. Star ratings measures used in scoring from Medicare HEDIS include improving or maintaining physical health, improving or maintaining mental health, monitoring physical activity, improving bladder control, and reducing the risk of falling. Mail with phone follow-up is the standard methodology for administration. And once the survey data is collected by SPH, it is submitted to CMS for reporting. And just remember, SPH is a CMS-approved Medicare HEDIS survey provider with more than 2 decades of experience surveying the Medicare population. Thank you.
Thank you, Steve. Our next speaker is Linda M. Lynch. Linda is a performance improvement consultant with SPH Analytics. Linda has more than 30 years experience in healthcare market research and strategy, including 16 years as Director of Market Research and Strategy at Blue Cross Blue Shield of Massachusetts. Welcome, Linda.
Thank you. So I'm going to spend a little bit of time talking about how you can improve your CAHPS scores and the member experience, and subsequently the star ratings that are involved with those same Medicare CAHPS scores. So first off, there are some basic strategies that the best plans use to continuously improve their member experience. And as has already been mentioned earlier in the presentation, looking at things through the eyes of the provider also can be helpful. I look at it as 2 sides of the same coin. The top plans look at everything through the lens of their members. They make decisions based on the impact on their members, and this doesn't mean that a plan always has to favor the member perspective. Sometimes that doesn't make sense, but at the very least, a plan becomes aware of the potential downside for members and can take appropriate steps to mitigate the negatives. Highly performing plans think this way all day long, every day. The idea of considering the member is part and parcel of everyone's job, and so it's enormously important that every single person who works the plan understands how what he or she does either impacts the member directly or impacts those staff who are interacting with members. And again, where possible, plans should involve providers and their office staff in day-to-day improvement activities. Next slide, please. Sometimes plans leave member and provider feedback information untapped. They don't pull together the information from various sources to help them understand what issues members are having trouble with or are complaining about. In figuring out exactly what needs to be fixed, there are a number of internal sources you can learn from. You should be talking to your frontline staff, people such as call center agents, provider relations staff. These are the folks who spend all day talking to your customers, members and providers, and they often know what's going on. They are often aware of problems before the problems show up on surveys or in other environments. Talking to these frontline individuals can often generate extremely helpful insights about members and providers. You also need to be looking at your call center data. Too many plans generate data from their call centers, but don't really use it outside the service center. If you see problems stemming from other areas, you need to be sure that information is shared back with the source. Many plans have advisory councils or panels made up of members or providers, and these are good groups from which you can get feedback. In addition, high-volume physician practices often have a good sense of where the problems lie, and it's very normal for what you see on the provider side to spill over to the member side and vice versa. So things that work well on one side usually work well on the other, and if you have a problem with one, it's often apparent to the others as well. You should always be reviewing your complaint, appeals, and denial reports to see how the information there aligns with other information you have. And some plans convene focus groups, informal or formal, to learn firsthand from their members what positive and negative experiences they are having. Next slide, please. Sometimes after you've conducted your Medicare CAHPS survey and might have a viable internal work group to help set improvement priorities and strategies, you find you still need more information to make the best decisions about what you should be doing. This is where a Medicare CAHPS drill down or simulation survey can be extremely helpful. For purposes of this discussion, I'm defining a drill down survey as a survey that asks drill down questions about the core Medicare CAHPS questions in order to better understand what barriers, problems, or issues your members are facing, so your plan can design more targeted interventions. This is information that isn't asked on the standard Medicare CAHPS survey, and you need to do a separate survey in order to drill down to the next level. It can take guessing out of your improvement plans. This survey generally contains closed-ended as well as open-ended questions, so members have ample opportunity to tell you what isn't working. And this survey doesn't need to be approved by CMS, so you can ask questions that are not allowed on the Medicare CAHPS survey. A simulation survey is actually just a replication of the core Medicare CAHPS survey to see if progress has been made before the next regulatory survey, or to allow oversampling or sample augmentation that isn't allowed with the Medicare CAHPS survey in order to provide more information than your regulatory survey can give you. For example, you might want to look at results among members seeing providers in various provider groups, and you can oversample to achieve that. Or you might want to look at members with certain financial attachments versus others. Or you can sample so that data can be cut regionally. You can sample in such a way that you have adequate sample sizes for any of these subgroups of interest, and this can help you target your interventions to the appropriate audiences so that you aren't trying to make a fix that cuts across your entire population, but really zeroes in on those where they're having the most problems. Next slide, please. Before conducting either a drill down or a simulation survey, it is really important that you as a health plan determine exactly what you hope to achieve. That helps you decide whether a drill down or a simulation approach is most appropriate. And if you know how you're going to use the results before you start, then the optimal planning can be done so the results are in fact what the organization wants and needs. A vendor like SPH Analytics can assist you and advise you through this decision-making process. Next slide. At SPH Analytics, for both drill-down and simulation surveys, we strongly recommend maintaining the mixed methodology of the regulatory surveys, but we generally limit the survey to one mail wave and then do phone follow-up. This allows us to condense the timeline so that you can get results much faster, and studies have shown that the results are fairly comparable. Since CMS discourages fielding surveys among Medicare Advantage members 4 weeks before, during, and 4 weeks after the regulatory surveys, this means a survey blackout period of approximately February 1 through June 30th is in effect. So our drill down and simulation survey clients conduct their surveys in the second half of the year. Many plans decide to do this soon after the regulatory results are available, so they have maximum time after getting drill down or simulation results to institute additional improvement efforts before the next regulatory wave takes place. I've already mentioned sampling for these surveys several times. Clearly, if you wish to be able to look at results among subgroups, it's important for us to work with you on an appropriate sampling strategy before the survey is fielded. We are available to give you advice and assistance as you make the sampling decisions in order to help make sure that either your drill down or your simulation survey provides you the information that you find most in need of. Next slide. I'll take just a minute to step back and talk about the high-performing plans out there. These are the plans that always end up at 4.5 or 5 stars and usually have attained excellent accreditation from NCQA. You know better than anyone that being a strong performing plan requires a lot more than simply the quality department hoping that they will be. And while every health plan is unique from every other in many ways, the best among them do share some common characteristics. These are the plans who live in a continuously improving environment. They have a strong executive commitment to improvement with a shared sense of purpose across the entire organization. They use available data and information to understand their members, providers, and other stakeholders. They stress accountability, but there is tolerance for thinking outside the box. Risk-taking is not just allowed, but encouraged. Decisions take into account the perspective of both members and providers. These top plans aren't solely claims payers, but they act as real resources for their members and their providers. And these plans know that improvement and high performance is a never-ending process. Continuously improving is the way that they operate. They are never at the end. Next slide. Many organizations I've worked with also undervalue the role of a member or member and provider satisfaction committee. The group can be called whatever you want, but a highly performing plan needs to have a group of employees from across the entire organization who are committed to improving the experience of their members. And again, I often say providers as well, because my experience indicates that provider experiences are really go hand in hand with the member experience. It's nearly impossible to have positive member experiences if there aren't positive provider experiences. Combining these two perspectives often sets the best plans apart from the others. Whether the member and provider groups function as one or as two separate bodies, they need a strong executive presence, going back to the idea of strong executive commitment, with regular working meetings where improvement opportunities and activities are reviewed and discussed cross-functionally. This is where all areas of the organization are forced to work together to achieve the goals, and the executive lets no one area slide. Next slide. At SPH Analytics, we have a team of performance improvement consultants who can help you. We have experience working on surveys and plotting improvement activities from both an outside vendor perspective and within a health plan like you. That's where our experience working at a health plan such as mine at Blue Cross Blue Shield of Massachusetts gives us the ability to really help our clients with what they need for an internal perspective. We can work with your plan to review your survey data, including your Medicare, along with other survey research you may be doing, such as provider satisfaction, call center satisfaction, image research, or whatever. We look for common themes that emerge from the research, and we can help you determine what your plan does well, where it falls short, and especially with areas regarding stars. We can then identify best practices for each of your weaker performing areas to help you make strategic and tactical changes for improvement. And we can also provide information and context to your organization to help you function more fully as a continuously improving organization. Next slide, please. We have worked with a client that needed more information to understand some drops and stagnations in their Medicare CAHPS scores for stars that they were experiencing. This plan conducted a Medicare drill-down survey with us and uncovered root cause explanations, which they were able to target. These improvement efforts included changes to their communication styles, enhanced member education about their drug benefits, outreach to providers about patient satisfaction issues, and enhanced access to after-hours care initiatives. So clearly, being able to do a drill-down survey and get additional information can help you target your improvement efforts more effectively. And now, more from Suzanne.
Thank you, Linda. So we just spent the last few minutes focusing on tactics and strategies related to CAHPS. And as we talked about at the very beginning of the session, that is one component of a star rating, about 13% worth. And then another big component is HEDIS measures. So the next couple of minutes, I'll just cover some areas that we've seen work for our clients in terms of improving their HEDIS scores and trends that we're seeing across the industry. So next slide. As you will recall, I brought this slide up earlier. It covers some of the key challenges our clients are facing, access to clinical EMR data, helping their providers close care gaps in a way that fits in with the provider's workflow and is timely, understanding those new member risk and history profiles, and then the area we just covered, which was measuring and improving member experience. But before I go into how we address and some good tactics for covering those, there's something that's new as of a week or so ago that actually ties in very closely to HEDIS, and that is the NCQA new standards category about population health management. So about a week or so ago, NCQA came out with the Health Plan Accreditation 2018, which includes a new category. And within that category of population health management, there are 6 standards. 4 of them are new, 2 of them are already existing. So wellness and prevention and complex case management exist already. But the new standards require plans to describe their comprehensive population health management strategy. They need to be able to integrate data to identify and assess the needs of members. They need to be able to provide data to the ACOs directly or provide practice transformation support to PCMHs. And they need to be able to conduct a comprehensive analysis of their pop health efforts. Such analysis should include measures related to clinical processes, member experience, and cost or utilization. And so the reason I bring this up is A, because it's relevant for this topic, but B, it is so closely related to some of the strategies that we recommend for improving HEDIS scores, because it's all about integration of data, clinical data coming into the payer, and claims data being able to be made available to the provider. And as you see on the right is a quote from Patricia Barrett, who's the VP for Product Design and Support at NCQA, and she talks about how data integration is key. The next slide. So talking about data integration, that topic on the top left of the previous slide, which was all about how do you access clinical data from EMRs in a way that isn't burdensome or obtrusive for the provider, isn't too costly, and doesn't result in fragmented files coming in from every single practice that you may work with. So this slide is very busy. It's just really to highlight an architecture that is a good way to think about it, and that is acquiring data from multiple different EMRs and filtering it through a warehouse that aggregates, cleanses, normalizes, and pushes to you, the plan, data from multiple disparate systems in a singular format that just contains your members. And this is our particular architecture and our approach to doing it. There may be other approaches out there too, but a couple of things that are really important to consider. First of all, when you're pulling in data from EMRs, there are various standard formats, HL7 results interfaces, ADT interfaces for demographics, and then the well-known continuity of care document architecture, or CCDA. The problem with those standards is, they tend not to be incredibly standard, so a CCDA feed from one EMR can differ quite considerably from a CCDA feed from another. But the other issue is they don't typically contain all of the data that you need in order to satisfy your HEDIS measures. So an example of that is if you're looking for the statistics about mammograms on women over 40 and you're pulling it from a primary care physician's EMR, the chances are that that PCP didn't perform the mammogram, so there is no procedure code in their EMR for mammogram. So our approach is we actually go directly into the EMR, and we have direct integration with over 40 EMRs, and we look for the presence of data in other formats. So if it's not codified, where is mammo or mammogram written in the chart or associated with the document in the chart? And so we pull out clinical data from a variety of different areas of the EMR and not just relying on that standard output. So that's number one important piece to note about getting data out of EMR systems. Number two is deduplication, which you can see in the bottom section of this data enrichment part of the slide here. So a lot of EMRs, every time a patient goes to the practice and they're generating an output or a CCDA of that patient's visit, they will generate a CCDA of the patient's entire history at that practice. And so you can imagine if the patient goes to the doctor more than once, you're getting multiple duplications of data because you're getting an entire history each time. So it can be very confusing. It can be hard to tell, was it 10 prescriptions that the patient got, or was it just 10 copies of the same prescription that you're getting in your data? So deduplicating the data in a smart way is really important. Normalizing it is important too, so that area called terminology management and data normalization. A lot of EMRs are going to use codes, local code sets. So, for example, if you want to look at lab results across your patient population, you want them all normalized to a format like LOINC, a national standard. And so if you're getting non-LOINC lab results in, you should have a way to be able to map those local codes to a national standard. And then, of course, you want to be able to know that a patient seeing Dr. A is the same as that patient when that patient sees Dr. B, even though Dr. A and Dr. B use different EMRs and have different medical record numbering systems. So there's a need to have a master patient index that can compare various demographics on the patient to know these two patients from these different practices are actually the same person, and be able to use that in terms of satisfying your quality measures. So those are just a couple of highlights of things to think about when you're pulling in data from multiple different EMR systems, and of course then needing to be able to ingest it into your own health plan data warehouse in a format that works for you. Next slide. We also talked about the need, the challenge that health plans have with enabling their providers to be able to close care gaps in a way that's easy within the workflow of their practice and more timely than kind of giving them a file at the end of the year and telling them to bring the patients in quickly before time runs out. So we work with a number of provider organizations as well as health plans with our tools that really take the data that's been ingested, whether it be EMR data and or claims data, and expose in a pretty practice-friendly manner where the care gaps are and help them close them. So it's hard to see on this screenshot, but just very briefly, the one on the left just compares providers across an organization and how they're doing quality-wise with care gap closure. And the screen on the bottom represents a particular chronic disease or quality measure, in this case diabetes, and within there some specific diabetes metrics for a particular practice or a particular ACO, and shows in green the number of patients within that practices or that ACO's population that are meeting the metric. The red ones are not meeting it, and the yellow are those patients that are likely to have a care gap in that particular metric in the next 60 days. And clicking on any of those bars can drill down and find that patient list to work on. And importantly, there are ways for the practice to be able to surround the provider, if you will, to help them close those gaps. So whether it be matching those patients up with what's on the appointment schedule for today and excuse me, providing the provider a list of these are my scheduled appointments for the day, and of those, these patients have care gaps that you should address while you're seeing the patient, and or being able to mail merge from this list a postcard or a letter out to patients to encourage them to come in and have whatever appointment needs to be done. And further, SPH, through our own call center, can also reach out to patients telephonically if the practice or the ACO doesn't have the resources to do that. So we really try and not just expose the care gaps to our clients, but also close them if they need help with doing that. And one other thing, sorry, just before we go there. being able to expose this data throughout the year when it's based on EMR data that's much more real-time than claims is very helpful in getting those care gaps closed while there is still time to close them. Okay, next slide. Just a couple more, and then we'll wrap up and ask for questions. So in terms of cost and utilization, of course, the other side of the equation when it comes to quality, we also have screens in our application to help our clients, particularly our provider clients, understand what the cost of their members are, who is, this screenshot in particular represents, the numbers here represent number of patients. So how many patients do I have in my various low, medium, and high-risk buckets? And importantly, the little arrows with the 225 and the 167 represents the number of patients that moved from a lower risk to a higher risk category in the previous month. So by drilling down on those numbers, you can really get to focus in on, you know, with my limited resources, what patients am I going to work on? Maybe you don't want to work on the very high risk patients because there isn't a whole lot you can change for them, but those ones that are starting to move are very good targets to work on. Next slide. And then this is just a different and more granular view of data in the cost and utilization area of our application, where you can drill down by plan, by type of member within the plan on their costs, the benchmark, the PMPM costs. You can compare it by providers and so forth. So slicing and dicing that data in various different ways. And of course, the foundation of this is the ability that we have to ingest both claims data as well as EMR data. And then the other thing that I had mentioned briefly was the challenge a lot of our health plans have with new members coming in, especially from the exchange. And one tool that we have to help them with that is by accessing a database that we have that has claims data, medical and pharmacy claims data, going back to about 2011, on average on about 55% of the population. It varies from state to state. A couple of states we've got over 80% of the population, but on average it's about 55%. And so what we can do is run a new member file from one of our health plan clients against this database. We run it through our risk algorithms and present back a risk stratified list of the new members along with their top 3 or 4 ICD-10 codes and corresponding HCC codes. So it acts as a nice, again, kind of tool to prioritize who am I going to focus on first, which of these new members should I plan interventions for. And I should have mentioned, it probably goes without saying, but this would be to look at the new members' claims from other insurance companies that they may have been with in the past, not the current health plan that they've just joined. And lastly, I just wanted to wrap up with an example of a particular client who has had a great improvement in quality outcomes through doing various of these strategies. That's Blue Cross Blue Shield of Louisiana. A couple of years ago, they implemented a patient-centered medical home program, and they used SPH's software to basically expose to the providers within the PCMH how many of their patients had care gaps in the various different quality measures they were measuring, and had basically a multi-pronged approach to support those providers with calling the patients in and closing those care gaps. And it had a very dramatic effect, not only on quality, but also on cost. So they had 25% improvement in diabetes measures, 31% in hypertension, 40% in vascular disease care, and 69% in kidney disease care. Now, this is obviously a state with, you know, on the lower end of outcomes across the country, so there was certainly room for improvement. But the point is that this was put out in provider practices. The average is probably 3 or 4 doctors, and really without impacting their workflow much, they made a dramatic improvement. And what happened was, as you would imagine, preventative care costs and visits went up because they were calling the patients back into the practice. Pharmacy costs went up because patients were filling their meds again. But there was such a dramatic decrease in ER and inpatient visits that the net result was, for Blue Cross Blue Shield, a $27.09 per member per month savings, and they had about 140,000 members that were in this program in the first year. So they had a pretty dramatic savings in year one, while quality improved at the same time, which is something that we always think is really, really hard to do. But these guys, and on their website, there are great links to the materials that they use to support their practices in this very holistic program that really blends in people, process, and technology. So that's the end of my part.
Thank you, Suzanne. We will now open the presentation up to questions. We have several questions lined up already, but if anyone listening has additional questions, please do type them into the Q&A tab of the WebEx portal now, and we will do our best to get to all of them during the remaining time. A couple of people have already asked, can they get the slides? So I just want to make that clear that we will be sending out the presentation slides and the recording in several days following the presentation. The first question I have lined up is, when is the best time to run a drill down or simulation survey for MCAHPS?
I can take that, Linda, unless you want to chime in, but I would say that the best time to conduct those would be after the regulatory season of CAHPS, so generally speaking, July through end of the year would be the best time.
And a follow-up question from that same person, what's an average time commitment for the consulting if we focus on improving star ratings?
Okay, this is Linda. I'll take that one. A typical arrangement is generally around a 10-week engagement, meaning that from 10 weeks after the contract is signed and work begins, there can be an on-site presentation with the appropriate group to talk about the improvement opportunities and best practices and that sort of thing. It can be sped up a little bit depending on the plan and how quickly things happen at their end in the early stages.
Thank you, Linda. I have a question here. This was one someone actually sent in as a registration question when they signed up for the webinar. The question was worded, how do we get the flu and pneumonia vaccine rates up?
This is Suzanne. I'll take this. This is obviously one that's a challenge for many health plans. So one way that we've worked with some of our clients to do this is we have an easy way to identify patients that are not compliant if our Nexus platform is in use, so the tools that I was just showing. So by pulling in both claims and EMR data, we have a very good cross-section of patient data. And then whether it's in partnership with the provider or in partnership with the health plan, reaching out to those patients that we've identified through through pulling them through our analytics. So with one particular client, we are sending out emails to those patients that we've identified through our email surveying capability, and then we are following up on the higher risk patients with phone calls just to make sure we reach them. But we can also certainly work with our clients with their own outreach and call centers as well if we give them the reports and show them the members that haven't had those flu shots.
Thank you, Suzanne. Another question.
Carrie, excuse me, this is Linda. I also want to say that some plans have been very successful in doing blanket outreach using IVR to just remind members that they should get their flu and pneumonia shots and where they can get them and how easy it is, like they don't have to make a doctor's appointment and that sort of thing, because there are still members in some areas that aren't aware of that.
Thank you, Linda. The next question, are there techniques to identify if a plan should oversample, and if yes, how much should be oversampled?
Sure, I can take that one, Terry. I think really the starting point for you would be to have a discussion with your sales executive to let them know that you're thinking about oversampling. We can look at a variety of different factors like your historic response rates, your historic oversampling levels, and we'll look at your composites that have low valid ends. There's several factors that we would look at. During the evaluation, your sales executive and the analytics team would come back to you with a specific recommendation for the amount of oversampling that would be most appropriate for your plan.
Great, thanks, Steve.
Yep.
Next question. If we segment, what are the most common types of segmentation to get the most actionable data?
This is Linda. I'll take that one. So there's a couple of things. One is if you want to segment in your regulatory phase, you have to have CMS approval, and they're pretty strict about making sure that you're going to have ample sample sizes in any of the segmentation groups so that it's impossible to identify members. And I have found generally they're much stricter. In other words, in the TAHPS, they won't let you show things with sample size below 11. But when you're asking about segmentation, they're often much stricter than that and want much more robust sample sizes. And so it is difficult to do a lot of segmentation with the CMS phase unless you're doing a fair amount of oversampling. If you do a drill down or a simulation survey, then there's no restrictions on that. And I have to say that in general, I don't find there's a lot of cookie-cutter approaches to segmentation that are useful. Some plans find that gender or education or health status or age are helpful segmentations. There are other plans where there aren't enough differences, and sometimes you don't really know that in advance. Many plans have found that large geographic units, such as counties or provider group breakdowns, are helpful. Usually they look at those analyses in conjunction with a drill down or a simulation survey. It's difficult to get those approved through CMS, again, unless you do quite a bit of oversampling. But a lot of it has to do with the health plan doing a good self-assessment of using other data that's available to them and educated guessing to determine what things they think might be the most actionable. Again, there's not really a cookie-cutter approach that says this always works, this always shows you things that you didn't know and that are actually actionable.
Thanks. Excuse me. Thank you, Linda. Next question. What are some strategies plans can use to drill down to member detail at the geographical level? In other words, I would like to know if a rating on specialty has any correlation with a specific county or zip code, and I would like to see that on a heat map.
This isn't too different from the question I just answered. So generally, you're not going to be able to do anything nearly at this level of detail during the regulatory phase. You're going to have to do a separate survey, either a simulation or a drill down, to look at this information. Even so, you're going to need to be sure that you have enough of a particular county or zip code, and that's even a tougher analysis to get at, in order to have viable data. Usually you have to look at your overall population and either through your own analytics or guesstimations, figure out what percent are going to be in one of these county or zip code ratings. And then if you really want to look at them robustly and you don't have enough naturally, then you're going to have to oversample or augment in order to get that information. It really is a matter of working closely with someone with your vendor, such as SPH, to determine what it is you're trying to accomplish and laying out a sample plan that's going to work for that. I don't know that we have generated heat maps with that, although certainly we can provide information so that you could do that if we are able to get that granularity of information. The other thing is that clearly, if you look, let's say, at preponderance within a particular zip code and the rating on specialty, that will be helpful in knowing that there's a problem with the rating of a specialist, but you're still going to have difficulty determining what type of specialist, what the reason for the lower rating was, and so that in itself might not really solve your problem. So you really need to think this through very carefully and figure out what is it you want to be able to do with the data at the end and sort of work backwards to make sure that the solution that you apply is actually a solution to the problem you have.
Okay, thank you, Linda. Next question. What EMRs does the SPH system connect to?
I'll take that one. So we have about 45 different ones that we connect to, and that includes all of the most common ones. So Epic, Cerner, Allscripts, Greenway, eClinicalWorks, GE, all of those. And as I mentioned earlier, with many of them, we have that direct database integration. So we go in pretty unobtrusively to the practice. They don't typically have to involve or pay their EMR vendor, which is important. And we pull exactly the data that is needed for the particular plan's quality measures.
Thank you, Suzanne. Next question. Can SPH help me with my cost and utilization trend?
I'll take that one too. Yes. So I showed a couple of screenshots of how we do that, and we most typically work on we can slice the data in multiple ways, but we're usually looking at a network of physicians like an ACO or a CIN, and then drill down into particular practices and particular providers to compare cost and utilization trends across a variety of different factors. The other thing that we are coming out with, which I think is pretty important, is a view, or like an executive dashboard view, of looking by practice, provider, or network of providers at their cost correlated with their quality, correlated with their experience. So is an ACO with higher cost than others, perhaps do they have the highest quality and the highest member experience scores? So that's something we're coming out with in the next few months, which is pretty exciting.
Thank you, Suzanne. We are nearing the end of our time. I'd like to go ahead and thank our presenters today, Dr. Roki Chauhan, Suzanne Cogan, Steve Brightwell, and Linda Lynch, for this enlightening presentation about improving your star power. As a reminder, we will email the slide deck from today's presentation, as well as a link to the webinar recording, to all of our attendees within the next couple of days. We'd also like to invite you, excuse me, slides are going crazy here, to look at our website for upcoming webinars. If you visit our website, it's sphanalytics.com/webinars, or you can click the News and Events tab at the top of the navigation, and you'll see the webinar drop down. We do host at least 1 or 2 a month, and would love for you to join us again on a future webinar. On behalf of SPH Analytics, we would like to thank you for joining us today, and we hope you have a great day and a happy Thanksgiving next week. Take care.